Lecture 2, Identification of Victims in Physiotherapy Settings. Hello, and welcome to the next lecture of our course. Today, we'll continue talking about signs of abuse and focus on their identification. We'll introduce different screening tools for various age groups. Following that, we'll touch upon the professional duty of candor. In the previous lecture, we outlined the various forms of violence and abuse: physical, psychological, sexual, economic, social, neglect, and institutional violence. Several of those forms often lack visible signs that allow for easy identification. Different types of violence can also occur simultaneously. For physiotherapists to assist victims of violence effectively, it is necessary to understand how to assess indicator behaviors or characteristics. Reflecting on such indicators can help in identifying and interpreting an abusive trajectory, especially because underestimating an abusive pattern can lead to both an escalation and a normalization of violent acts. Violence can be perpetrated in both direct and indirect ways. Some forms of violence are subtle. If you can recognize signs of abuse and have the knowledge of necessary tools and techniques for supporting victims, you'll play a fundamental role in empowering and protecting these victims. The role of all professionals and services is vital for combating DV in our societies, ensuring access to information, raising awareness, providing support, and mitigating abusive patterns. To formulate an appropriate treatment plan, you need to know and understand available tools. Unfortunately, there are no institutionalized protocols or specialized training programs for physiotherapists to provide understanding of DV or IPV, its forms and signs, or legal procedures for dealing with violence after disclosure. The goal of this lecture is to offer guidelines to establish a relationship of trust where you, as the physiotherapist, have the knowledge and skills to recognize and support victims of DV or IPV. Recognizing signs of abuse. Considering the high risk of women being victims of violence and the high prevalence of DV in the population, physiotherapists need to be able to identify its signs. Almost 1 in 2 women in the EU have experienced psychological violence, and 1 in 3 women in the EU have been victims of physical and/or sexual violence. Many signs of different forms of abuse are listed in the previous video, but we'll highlight a few of them once again. Recurrent broken bones, sprains, dislocations, abrasions, welts, rashes, blisters, burns, lacerations, edema, swelling, contusions, frequent bruising, concussive injuries, signs of being restrained, ankle or wrist bruising, abrasion, weight loss, hair loss, poor hygiene, lack of awareness, drowsiness, vagueness, confusion, sleepiness, grogginess, cringing or acting fearful, agitation, shutting down behavior around the carer or relative, inconsistency, delay or non-attendance at scheduled appointments, resignation, neglect of personal needs or disinterest in personal expression and communication, and expressing anticipation of mortality, perceptions of death as redemptive. You can use these signs in identifying and monitoring DV or IPV cases, especially if you are able to note changes over the course of an extended treatment regime. Violence screening tools. There are methods and tools integral to a holistic response to DV or IPV. Basic steps include creating a relationship of trust and safety, assessing the situation and collecting information, and approaching professionals in other sectors to support the beneficiary, for example, social services, support services for victims of violence, doctors, lawyers, police, prosecutors, etc. Following those 3 basic steps can ensure the safety and protection of victims and become a cornerstone for a more effective provision of care and support by various professionals. When it comes to assessment of your patient, there are some practical tools that makes this process easier for you as a professional. The screening process assesses through a series of questions the possibility of your patient's exposure to DV or IPV, as well as the risk of being subjected to it. The use of screening and risk assessment tools is a primary intervention, one that initiates a process of cooperation between you and your patient. There are, of course, multiple screening forms available for you to use when you think that your patient may be a victim of DV or IPV. We divide these into 3 types depending on the target group. Those you can use for adults, elderly patients, and minors. One of the recommended forms to perform screening of adults is from the Finnish National Institute for Health and Welfare. It includes several steps, the first one consisting of 4 basic questions. If the answer is yes to more than one question from this list, then you move to the next step and ask follow-up questions. The first 4 questions include: is there physical or emotional violence or abuse in your close relations at the moment? Does the violence that you experience affect your well-being or life management? Have you been sometimes earlier in your life a victim of physical or emotional violence or abuse in your close relations? Does the violence that you experienced in the past still affect your well-being for life management? The answers to the above questions can be yes or no. The follow-up questions are more specific, and they include the following. What kind of DV or IPV have you experienced? When was the last time you were a victim of DV? During your whole lifetime, how often have you been a victim of DV? Who has committed DV against you? How would you describe the effects of the violence on your well-being at the moment, using a scale from 0 to 10? How would you describe the effects of the violence to your safety at the moment, using a scale from 0 to 10? What kind of help would you like to get? Have there been any underage children present and exposed to violence in these situations? Practice sensitivity and empathy in formulating those questions for your patient. Inform the patient about possible follow-up actions. Provide them with information concerning the support services available, and proceed with a referral to the competent services and authorities. We'll look into various support services in the next video lecture, but meanwhile, here is the list provided to Finnish practitioners. The patient may proceed dealing with the issue as part of their treatment with me. I have referred the patient to the doctor. I have filed an official child protection notice. I have contacted the police. I have contacted the social emergency duty at the patient's home municipality. I have contacted the local crisis center. I have referred the patient to the local crisis center. I have contacted the shelter. I have referred the patient to the shelter. I have prepared a preliminary safety plan with the patient. I have advised the patient to prepare a safety plan for themselves and/or their children. I did something else. This needs to be described in the form. There is no need for further operations because the client is already involved with an appropriate institute, for example, family counseling, therapist, social work. Another comprehensive tool is DASH, or Domestic Abuse, Stalking, and Honor-Based Violence, widely used in the UK by police, healthcare professionals, and social workers. It is used to identify and manage domestic abuse, stalking, and honor-based violence. Its primary objective is to keep victims and their children safe, while ensuring perpetrators are proactively identified and managed. Screening adults for a history of sexual assault in physiotherapy is crucial for enhancing treatment adherence and ensuring a patient-centered approach. By proactively addressing the potential physical and emotional sensitivities associated with past trauma, physiotherapists can establish trust, create a safe therapeutic environment, and tailor treatment plans to individual needs. This proactive approach not only prevents re-traumatization, but also acknowledges psychological barriers and fosters open communication, enabling patients to actively participate in their care. Early identification of survivors of sexual assault is essential for preventing long-term physical and mental health consequences. Healthcare providers should be aware that certain medical procedures, such as pelvic, rectal, breast and endovaginal ultrasonographic examinations may trigger panic and anxiety in patients with a history of sexual abuse, often linked to post-traumatic stress disorder. Counseling plays a vital role in helping sexual assault survivors comprehend and manage their psychological and physical responses. Sample sexual assault screening questions include: has anyone ever touched you against your will or without your consent? Have you ever been forced or pressured to engage in sexual activities when you did not want to? Have you ever had unwanted sex while under the influence of alcohol or drugs? Do you feel that you have control over your sexual relationships and will be listened to if you say no to sexual activities? Is your visit today because of a sexual experience that you did not want to happen? There are also separate screening tools designed specifically for elderly patients. One of them is EASI, or Elder Abuse Suspicion Index, which is a 6-question rapid screening tool. Another option is REAMI, or Risk on Elder Abuse and Mistreatment Instrument, a risk screening and assessment tool used by social care and mental health professionals. We will not go through EASI and REAMI questions now, but you can find them attached to this module's course materials. Here, we wanted to introduce the simplest risk assessment screening tool, the HS Elder Abuse Screening Test, or HS/EAST. It includes 15 questions in total. Do you have anyone who spends time with you, taking you shopping or to the doctor? Are you helping to support someone? Are you sad or lonely often? Who makes decisions about your life, for example, how you should live or where you should live? Do you feel uncomfortable with anyone in your family? Can you take your own medication and get around by yourself? Do you feel that nobody wants you around? Does anyone in your family drink a lot? Does someone in your family make you stay in bed or tell you you're sick when you know you're not? Has anyone forced you to do things you didn't want to do? Has anyone taken things that belong to you without your approval? Do you trust most of the people in your family? Does anyone tell you that you give them too much trouble? Do you have enough privacy at home? Has anyone close to you tried to hurt you or harm you recently? When it comes to the screening of minors, there are separate assessment tools to consider. The Pediatric Hurt, Insult, Threaten, Scream, Sex, PEDHITSS, is a 5-item validated screening tool intended for clinical settings. The tool screens for physical, psychological, verbal, and sexual abuse, but not for neglect. The primary purpose of PEDHITSS is to identify and address the risk of violence in pediatric patients and to provide appropriate intervention and support. It is useful for children ages 12 and under. PEDHITSS has been validated by asking a parent or guardian to fill in the questionnaire, but it could equally be filled in by physiotherapists via gentle probing where answers are never prompted. Teen dating violence, or TDV, is prevalent among this age group. It encompasses psychological, physical, and sexual aggression within the dating relationships of adolescents aged 13 to 19. Due to their developmental stage, adolescents may struggle to employ positive relationship skills, often resorting to anger, physical aggression, and emotional abuse during conflicts. Unlike adults, adolescents typically do not cohabitate, share finances, or co-parent, diminishing the adult power dynamic in teen relationships. While teens recognize the allure of material and sexual benefits in relationships, peer pressure and social influences heavily shape their decisions. Young women, aged 16 to 20, experience the highest rates of relationship violence, surpassing even adult women. TDV is closely associated with socioeconomic status and risky behaviors such as unprotected sex, substance use, self-harm, and disordered eating. Unfortunately, there is currently no widely accepted screening tool for TDV. The professional duty of candor. The professional duty of candor is a fundamental ethical obligation within the healthcare profession. It emphasizes openness, honesty, and transparency in communication between healthcare providers and patients. It requires healthcare professionals to be forthright about any mistakes, errors, or adverse events that may have occurred during the course of patient care. This duty extends beyond just disclosing information to patients. It also involves keeping patients informed about the steps being taken to address the issue and prevent its recurrence. One of the main benefits of the professional duty of candor is the promotion of trust between healthcare providers and patients. Open and honest communication fosters a collaborative and trusting relationship, enabling patients to make informed decisions about their care. It also contributes to a culture of safety within healthcare organizations, as it encourages the reporting and learning from adverse events. This transparency is crucial for the improvement of patient safety and the overall quality of healthcare. Additionally, the duty of candor aligns with ethical principles such as autonomy and respect for persons. By providing patients with honest information about their care, healthcare professionals empower them to actively participate in decision-making processes related to their health. This shared decision-making enhances the patient's sense of control and autonomy over their healthcare journey. In the broader context, the duty of candor plays a vital role in improving the overall healthcare system. It contributes to a culture of continuous learning and improvement by encouraging healthcare providers to analyze adverse events, identify root causes, and implement changes to prevent similar occurrences. In essence, the professional duty of candor creates a supportive and open healthcare environment that is essential for identifying and assisting victims of DV. It contributes to a comprehensive approach that goes beyond medical treatment to address the holistic well-being of individuals affected by DV. That concludes today's lecture. Thank you for watching. In the next lecture, we will continue discussing possible ways of helping victims of violence. Don't forget to complete the weekly assignment to progress to the next module of the course. See you in the next lecture. Goodbye.